Good evening to you all. I'm Dr. Sundaresan, the president of Batticaloa Medical Association. So today we have a special guest. He is doctor from Mumbai, India. He is Dr. Darrell Demello. So first of all, the Batticaloa Medical Association, welcome Dr. Darrell Demello. Welcome, sir. I came to know about him through the YouTube star, Dr. Mobin, a well-known physician among the YouTube medics. And I know if Dr. Mobin interviewed someone, there should be something special in him. So then I listened to your talk in the YouTube, and I really fascinated by the unique way of you treating the COVID patient. Dr. Demello has treated, I think by this time, more than 7,000 COVID patients. And I heard that he lost only 14. That's nearly when I checked, 0.22%. If you see the global figure, it's about USA about 2%. Some countries it's 3%. India, I think about 1+%. Sri Lanka also somewhere there. So it's a great achievement. So then I thought there is something we can learn from him. And that's how Dr. Demello is here. And the other important thing is he usually what I heard is most of the management he did is through telemedicine. And now we are eagerly waiting to listen to Dr. Demello. And so there will be a talk for about 20 minutes or 20 plus minutes by Dr. Demello. In between, the moderator may ask 1 or 2 questions if necessary. And we make sure that he is willing to do so. Then thereafter, meanwhile, the participants can send your questions in the chat box. So at the end, Dr. Vishnu is with me, and he's a pediatrician. He's a moderator here. So at the end, we'll take your questions. Now, Dr. Demello, you can start. And it is live. I think it will be shared in the Facebook also as well.
Good evening, everybody. My name is Dr. Demello. I'm from Mumbai, India. And I want to say thank you to Dr. Sundaresan and Dr. Vishnu for the invite. I'm delighted to be here and here to discuss and share my experiences with treating COVID. I started with COVID last January. I started learning about COVID. I started researching COVID January, February, March, April. And I came across very interesting things. One was that, yes, in China, they said it was a viral disease. So did the Italian guys, so did the US, Spain and UK. That's when we all got hit. Then we looked at, what Italians came up with the autopsy of 50 dead bodies. And they came up with the idea that this is a clotting disease. They saw clots in the lungs. That changed a lot of our approaches to how we dealt with the disease. This is not a classical bronchopneumonia type interstitial lung disease. This starts as that, but moves on to being a clotting disease very fast. So microvascular clotting in the lung tissue happens, and then the major vessels, the minor vessel and major vessels happen, and it goes from there. So that thing towards the end of March, I think it was around the 3rd week of March that we learned about the Italian study. And as I researched my drugs, I was looking for an antiviral. It's a viral disease, so I wanted to kill it or reduce the growth of it. The second one, we had inflammation, so I wanted to look at inflammation. And the third thing, since we're clotting, obviously we're going to use something to prevent clotting. At that time, I started with aspirin. But for the viral part, the study out of Australia, which talked about, that's the lab study, which talked about 5,400% better than anything else. And that one dose of 12 milligrams kills 99.8% of the virus in 24 hours. That made a big difference to my way of thinking. Yes, there was no clinical trials. There was no hard data to talk about it. And, I come from the medical device and pharma background. I've been medical advisor to two big US companies, Wyatt Laboratories and Leatherly. I've been in management in both Leatherly as well as in device companies like Bard, CR Bard, and then Boston Scientific. If you've heard the word angioplasty, I'm the one who introduced angioplasty to this country, to this region, to this country, to Sri Lanka, to India, and all in '89 onwards, and introduced stenting in '94 to '96. So I've done a lot of things in the vascular, cardiovascular space, AAA stenting, neurovascular stenting, gastroenterology, any of the tubes of the body. I've had a hand in the development of the procedures as we've gone along. So COVID, when I learned about COVID, the three things: inflammation, clotting, and virals. So I basically was, for inflammation, I was looking for a drug that gave me something similar to what tocilizumab does. And tocilizumab is very expensive for our countries. And that is probably the best drug to give within 48 hours of the cytokine storm. That is the only window of opportunity to give tocilizumab. Giving it at day 17 and 15 and all, I've had all kinds of stories from all kinds of doctors saying they give it as an antiviral on day 17 and I laugh. You have no idea what they're doing. So I've had all kinds of discussions about tocilizumab. I was looking for a drug that got me down interleukin-6, interleukin-1 and 1A, and I found a drug called colchicine, COLCHICINE. That is my anti-inflammatory drug that I start with. Second one was antiviral. I use ivermectin almost in 100% of my cases, except when a patient comes to me after day 9 or 10 when I don't use ivermectin. But any patient coming earlier than that gets a dose of ivermectin. I use a 2-day, 4-dose thing. So morning and evening, 12 milligrams, 12 milligrams, 12 milligrams, 12 milligrams, and it's done, okay? I then focus on the anti-inflammatory side and then focus on the antiviral. Antiviral, of course, is the ivermectin, like I said, and focus on the anti-clotting drug. I changed from using aspirin to actually using clopidogrel after around 200 cases. After having a couple 200 cases, then I changed because I saw a bounce back in platelet counts. Usually in COVID, the platelet counts will be depressed, will be 80,000, 100,000, 140,000. The standard should be between 150 and 450. I would see a bounce back to 500,000, 550,000, 600,000, as high as 750,000. As you know, platelets cause clotting, so that kind of added to my thing. So I went for an anti-platelet agent, clopidogrel, which is Plavix, or whatever name you call it. I mean, you may have different 100 brands of that is available. So I use that as my anti-clotting drug. Right up front, I don't even wait. And I have a mantra, and I'm going to share this with you. Treat first, test later. Do not worry about your RT-PCR test. Don't worry about your HRCT. Don't worry about your blood test. You make a clinical diagnosis of COVID clinically, treat. You have nothing to lose, okay? The drugs are very inexpensive. You're safer treating patients from in that day 1 to 4 rather than waiting for 5 to 7, and worse is when you get to the 8, 9, 10 days. So please, I really suggest and recommend you to initially make the diagnosis of COVID and move on and treat. Today, there's nothing called flu. There's nothing called viral fever. Okay, there's nothing called norovirus, which is stomach flu, where you have diarrhea. Today, it is all the ninja mutant story. COVID has taken over the world. There's no other virus that's in existence. I'm dealing with 2 family members basically today who have, one has just pure diarrhea 18 times a day. I finally stopped it after 3 days. And the second one has 10, 12 times a day, but she has other issues like, respiratory, throat irritation, nose running, all that, headaches and body aches and all. So 2 different people, 2 different symptoms and 2 different presentations. Both common are in COVID. Okay, so vomiting and nausea are some of the symptoms. Respiratory, diarrhea, body pain, headaches are all symptoms of COVID. So both have got treatment for COVID, and one is on day 5 or 6 today, and the other one's on day 3. So It's about going through the day. This is a 14-day disease. Work with the 14-day. Do not allow a patient to say, oh, I have only fever only for 3 days. Please, if they've had fever for 3 days and their oxygen saturation ratio is 90 or below 95 or below 90, treat it as a day 9 or 10 patient, which means going into anti-clotting, aggressive anti-clotting thing. I use very aggressive methods for anti-clotting. I use enoxaparin, low molecular weight heparin, and I use it in a dose of, depending on the weight, 1 milligram per kilogram body weight. Usually I give 60 milligrams twice a day for 5 days, and then 60 milligrams once a day for 10 days. That's my initial treatment for enoxaparin. I may go higher to 15 days. I may cut it down to 7 days, again, depending on how fast the patient reverses. I do use this in a post-COVID scenario, one, two, or three, but we can talk about that later in the question answer. We can talk about that. I've had great success. I've been quiet. I've kept my head under the radar and kind of gone out and just treated. I use telemedicine primarily. 85% of my patients are telemedicine across the country. Now it's across the world. I do see patients at home in my home clinic where I'm sitting talking to you. On the right-hand side is my clinic. So I do sit here and see patients. And I've probably seen about 10-15% of my cases have been telemedicine. Today, the latest numbers are somewhere around the 7,500 mark. So I've done a lot of cases. My admissions are about in the low 40s, so 42 or 43. I have about 16 deaths. And deaths are going to happen. It's not that you are going to be death-free. Admissions will result in deaths, especially if you can't control. I've taken people from oxygen saturation ratios of 60 in the morning to 96 in the day. I've taken people from 66 to 81, not been able to get them up above 85. Had to admit that patient, lost her. 2 days later, I lost her. I've had a patient who was 85 when she came to me. However, her HR, her high resolution CT scan of the chest was 20 by 25. So that night I admitted her. She died a day and a half later. Okay. So I've learned one lesson with HR CTs. Anything above 20 is very difficult. I've had good success also with the 23, and I'll share that story with you in a minute. However, I've had good success with HR CT scans, severity scores. Anything above 10, I start with enoxaparin and reverse them. Usually around between the 15 by 25, you can bring that down to 0 within 30 days. So again, you don't want to leave any kind of a lung fibrosis issues or liver problems or any other organ problems. So my goal at the end of 30 days is try to have the patient back to as normal as possible. I do not do blood tests unless it's day 7 or 8 and fever is still prevalent. Or if a patient has had fever initially, no fever for 4 days, and again fever starts on day 7 or 8, then I will investigate a little bit more aggressively and go with that. So again, there's a lot of ways of how you can do this. No two patients are identical. No two patients present with the same symptoms, same outcomes, same results. So there's really no fixed protocol or fixed thing to do with this. The basic protocol is anti-inflammatory, antiviral, and anti-clotting. I use, like I said, I use colchicine, I use clopidogrel for anti-clotting, and I use ivermectin. Obviously, ivermectin is used to prevent the replication of the virus and then go from there. So if the virus is stopped from growing, then the body can take care of the rest. Colchicine can do what it needs to do. So I use a lot of strategies. I'm very aggressive when it gets below 90. When the only hard point I depend upon is oxygen saturation ratios. That's a hard data point. Temperature, yes, and heart rates, yes, but not to that extent. Temperature, I've had patients all the way up to 14 days with fever. Never bothered about them, as long as everything else was fine. I've had people normally by day 10, 100% of the people, or 99% of the people will have normal temperature. If you especially watch for this, And I'll give you one tip. Anybody who's had fever first day or two, and then fever, without temperature of 100 or more for 3, 4, 5 days, 6 days, but start with a fever on day 7 or 8. They're clotting off. Their inflammation has gone way above anything. Let's talk about the variants. The Delta variant and the Delta plus variant, what they've renamed it now. That is the Indian variant. That's been around for, what, 8 months, 9 months, 10 months. It's been around in India for a long time. We've treated that. The Delta plus, I'm pretty sure I've treated at least some amount of Delta plus in the last 3 months. When we had the surge and we had a lot of patients, we've treated some of the Delta plus patients. It's only now that the sequencing is being done and everybody's identifying it. The treatment that I started last year in May is the same as what I'm doing today. It's not changed. The only thing that I changed was using aspirin. I'm using aspirin to going to clopidogrel. I do use enoxaparin a lot. I don't use steroids. The reason, because I don't use steroids, because I'm using colchicine right up front. If I use steroids, it'll be on day 7, 8, 9, or 10, when I'll start a low-dose dexamethasone strategy. You could do a methylprednisolone strategy. It doesn't matter which steroid you use. But if you need additional firepower, you need additional help to reduce the inflammation, start with steroids. So I use steroids as a backup. In my first 3,000 cases, I used steroids for about 7% of cases. I haven't done an analysis in the next 3,000-4,000 cases so far, how much of steroids I've used. I'm guessing it'll be a lot more because we've had a lot more disease patients now than what I saw in the first 3,000 patients. There are 2 reasons it could be. One is that patients tend to self-medicate for the first 3 or 4 days because of the fact that the variants are less virulent, so they're less potent. So the symptoms are less than what we used to see last year. The symptom that the patient has is much less. And so patients tend to sit on the symptoms, not come to you. By the time they come to a family practitioner, it's probably day 4. And the family practitioner says, oh, this is flu, this may be viral fever. 3 days, it doesn't go away. Then you say, okay, get me a blood test, get me this, get me a CT scan. It may be too late. A lot of patients have started, a lot of family practitioners have started using steroids on day 4 or 5. That, along with favipiravir, sometimes results in accelerated clotting. I'm seeing a lot of accelerated clotting. When I say accelerated clotting, I'm talking about clotting that shows in the CT scan of above 10. Usually it'll be 15 by 25, 18 by 25, 17 by 25, 20 by 25. So be careful of this. These are some things that within 24 hours, a 10 by 25 can become a 23 by 25 within 24 hours. So if you see a 10 by 25 or 12 by 25, please start enoxaparin. Start anti-clotting aggressive. That's what will help you, okay? What else can I share? I'm trying to think of Dr. Vishnu or Dr. Suresh, any question? Any quick
here, of course, yeah, thank you. Thank you for, it was